The cornea is the eye's window. To perform its function, it must be transparent and have a regular curvature. Any corneal injury can significantly compromise vision. Therefore, suturing the cornea requires special attention compared to other areas. Specifically, it is essential to restore the eye's integrity, minimizing scar tissue formation and its subsequent impact on transparency, while preserving the regularity of the curvature as much as possible. Since irregular astigmatism cannot be optically corrected, it's important to keep in mind that the cornea has a curvature radius of about 7.5 millimeters, while the sclera has a much larger curvature radius, generally over 10 millimeters. Therefore, when preparing to suture a corneoscleral wound, one must think in 3 dimensions. The stitches should be placed while keeping the needle perpendicular to the tissue being sutured. In these images, we can observe how the needle's angle changes at different points on the sclera and the cornea. Care should be taken not to manage the eye as a flat surface. As a first step, it is important to re-establish a clear separation between the cornea and the sclera by placing an absorbable suture on the scleral side of the limbus and a nylon suture on the corneal side. The sutures close to the limbus can be tightly secured because they help bring the wound edges closer together without inducing astigmatism. Subsequently, the suturing of the cornea is performed. The presence of some irregularities in the wound sometimes allows for finding the correct alignment of the 2 wound edges. Short, almost full-thickness sutures placed at the center of the cornea help restrict the flattening of the cornea and scarring tissue formation. This approach minimizes induced astigmatism and reduces the surface area that loses transparency. If long sutures are placed at the center, they tend to flatten the apex and induce significant irregular astigmatism, in addition to increasing the area of scarring. It's crucial to achieve watertight suture of the anterior segment while performing the necessary manipulations to inspect the extent of the scleral wound. The process involves placing a suture at the midpoint of the remaining wound extension, and then again at the new midpoint, ensuring an even distribution of the tissue. Injecting viscoelastic substance into the anterior chamber through a paracentesis during the suturing procedure can help restore volume and facilitate the process. Subsequently, the suturing of the scleral wound can be carried out. If the end of the wound cannot be identified, it may be necessary to disinsert the muscle for inspection. Proper suture placement is essential to prevent tissue overlap and the onset of irregular astigmatism. To achieve this, the suture should reach about 90% of the corneal thickness at the edges of both inner sides of the wound, and its length should be symmetric relative to this point. For a laceration perpendicular to the corneal surface, the bites look symmetrical whether viewed from the inner and outer perspectives. If one side is longer than the other, the longer side exerts greater tension and tends to cause the margin to override. When managing a shelved wound, it's essential to align the inner edges accurately, regardless of any asymmetry in the outer portion of the suture. In case of irregular corneal wounds, focusing on the symmetry of the sutures on the epithelial side rather than the endothelial side can increase the risk of wound edge overlap. At the end, it is crucial to restore the intraocular pressure to be able to comfortably bury the knots. Furthermore, at this point, it may be necessary to replace some sutures to fine-tune their tension.